So what we're going to talk about today is applying rational lab testing in different clinical scenarios. The whole goal is to try to be very practical about how we can actually apply it in day-to-day practice, and we'll go through some case scenarios together. So in terms of conflicts of interest, I have no relevant conflicts of interest. I do receive a salary from the Therapeutics Initiative in UBC for the research work I do, and I have some funding from nonprofit organizations for the research and lab testing. So objectives, two main things that we'll work on today. One is we'll review the concept of laboratory misutilization, and then we'll try to apply an approach to rational lab test selection using case examples. So I always like to start with this slide because, well, we need to talk about why we're even talking about this topic. So why are we talking about lab testing? We're talking about it is because it's actually the most common medical activity that any Canadian will engage in. This is their interaction with the healthcare system that's most frequent. Most Canadians will get tons of lab tests over the course of their lifetime. And our utilization of these lab tests is increasing at a rate of 6 to 8% per year compared to population rate increase, which is around 2%. So we're doing a lot more of these tests. And unfortunately, even though we're doing more of these tests, we're not necessarily doing them well. So we're doing a lot of tests that are not useful, that are leading to false positives, and is causing a lot of complications. Those complications are at the patient level, who are getting unnecessarily phlebotomized, who have pain, discomfort. They have to go get these tests done. They're at the health system level in terms of wastage, but they're also at the physician and the ordering person level because it's just tons of lab tests that people have to review. People are more likely to miss important test results because they just have so many lab results that they're reviewing and reviewing. So there's lots of opportunity in lab services to improve how we do things. And kind of applying a more of a theoretical concept here, but optimal use of lab testing requires two things, the way I see it. One is purposeful selection of tests. So this cartoon on the left is meant to illustrate that every patient is different. No two people are the same. And you really have to think about applying the right test to the right patient in the right time. And the figure on the right shows that we need to move away from the concept of routine labs, so that this is a person who needs all of these tests, and really think about, well, where is this patient coming from? What are the medications they're on? What are their comorbidities? And based on that, am I ordering a test because I anticipate a complication that the patient might be undergoing, or because something has changed in the patient's condition and I'm trying to work up a sign or a symptom? So really kind of being purposeful about the ordering of lab tests as opposed to trying to just routinely apply a battery of tests to patients on a regular basis. And then once you've applied the right test to the patient at the right time, the second is the accurate interpretation of results. So we get a lab result value, we get reference ranges, and then we have to sort of figure out, well, what does it mean for the patient? This figure illustrates that, yes, we get the lab results, but we have to really think about it in the context of the patient's other medications, their demographics, and their age, sex, gender, because all of these things can impact what the expected reference interval might be for that patient. And then we think about, is this test result something that we need to act on? An example may be TSH, which I'm sure many of you have seen, that is marked as abnormal. But then the question that we have to ask ourselves is, in the context of my patient, does this abnormal TSH result mean anything? Do I have to act on anything? Or is it something I can just file off and monitor? So laboratory test misutilization is an umbrella term which looks at both overutilization and underutilization. So underutilization is when a person should be getting this test for screening or for diagnosis or for monitoring, but that doesn't happen. And that is a problem as well. And overutilization is when there's too many tests being applied indiscriminately to patients who don't need it. And then you end up dealing with a lot of results and not knowing what to do about it. So the overtesting cascade is when healthy patients are administered diagnostic tests indiscriminately without considering what your pre-test probability for disease is in that patient. There's going to be an increasing chance that you're going to pick up false positive results. And then these false positive results might lead you to doing more tests. And then that might lead you to an incorrect diagnosis or overtreatment. And then there's an entire cascade that sort of increases at the patient and the health system level. An example I see often in hospitals is when patients just get blood cultures drawn at admission, regardless of the cause of admission. And then we see these contaminant species, coagulated negative staph, that are often growing in these patients. So a few Hours later, a couple of days later, we'll say gram-positive cocci, we should be, and then these patients get started on antibiotics, often vancomycin. And then 2 or 3 days later, the final confirmation will come, which will say, oh, this is a coagulase negative staph, 1 in 4 bottles, not really an important pathogen. But by then, the patient has been on something like vancomycin for a day or so and might have suffered complications already. So doing a test that was unnecessary at the beginning can have quite a significant downstream cascade of complications. So now we're going to just review some of the practical pearls to improve the value of lab test utilization as an individual practitioner, and then we'll talk about examples of this going forward. So 1, use lab testing guidelines when available. So there's not guidelines for every test, but when guidelines do exist, they help. And they help because they make it easier to say, this person does not need this test at this time. And then you've saved yourself, the patient, and the system all the downstream cascade of unnecessary tests. Second is avoid redundant testing. I know it's often difficult based on EMR systems and so on, but lots of patients have redundant testing, which means they've had a TSH done that was normal, 2 months later they have it done again, and 2 months later they have it done again, and it keeps getting repeated and repeated. And is redundant at this point. It's not, it's normal, and we're just repeating it because there are multiple providers. Maybe don't all have access to Care Connect. Maybe Care Connect's down when you're trying to order the test. There's many things, but it does contribute to a lot of redundant testing. Use of stepwise testing over order panel testing, and we'll talk about some examples of that as well. And consider retesting intervals for individual lab tests. So once you have a lab test and its result, really think about when that needs to be repeated. And also knowing your specialized tests. There's lots of specialized antibodies, hormones. When do you test? When do you call a friend? When is it actually cheaper and actually less time consuming to call a friend and ask whether or not this test should be applied versus just going ahead and ordering it and then having to deal with the consequences. So, what do I make of this weird and abnormal test? So clinical scenarios. Just a quick disclaimer here. This is not comprehensive whatsoever. I've picked certain tests, and they've picked these tests because they're common. They've been picked by Choosing Wisely Canada or the BC guidelines, and they actually might help illustrate how we can apply rational lab testing in clinical scenarios, and they can be applied to other scenarios as well. So this is a case example. So you're assessing a 65-year-old male patient in your clinic, and he's had a recent diagnosis of diabetes. After an appropriate trial of lifestyle modifications, his hemoglobin is still not quite at the target that you and him are hoping he should be at. So you initiate him on pharmacotherapy. And then the thought is, when would you check his hemoglobin A1C next? So the answer here is 3 months. And this has now become a recent Choosing Wisely Canada kind of recommendation as well, is don't repeat hemoglobin A1C testing within 3 months of a previous result. So you continue to follow up with this patient over a period of a year, and now his A1C is at target. He's been following a very stable prescribed exercise regimen, and he's kind of following a stable diet as well. How often would you monitor his hemoglobin A1C at this point? Options are 12 months, hands for that, 6 months, 3 months. Good. So 6 to 12 months is kind of the right answer for this. So BC guidelines say if their treatment and lifestyle recommendations are stable, think about 6 months. Choosing Wisely says 6 months as well. A word on the evidence. So I did a lot of searching to look at where these months and timelines and stuff come from. And really all of the evidence for this comes from expert consensus and laboratory and clinical experience. So we don't really, unlike medications, we don't really have a lot of cohort studies or trials to show that this is the right amount to do. But where it comes from is, what is there in this photo? What am I showing here? Exactly. It comes from red blood cells and the average lifespan. So hemoglobin A1C is glycosylated red blood cells, or hemoglobin in red blood cells. And the average lifespan of a red blood cell is around, exactly, it's around 3 months, so 120 days. So the point is that, or 90 days. So the point is that if you check the hemoglobin sooner than that, there's not going to be enough turnover in the red blood cells to reflect the new change. And that's why we do 3 months. So that's why, even though the evidence here is not as strong as what clinical evidence or ABM would require us to do based on this pathophysiological reason, we would say that really if you check it within 3 months, it's not going to be reflective of any change you've made in the patient, to the patient's treatment. So this is a different case example on different tests. So you're assessing a 45-year-old female in your clinic who's presenting with nonspecific fatigue and arthralgias for 2 months. You notice that she's had an ANA test that was performed that was negative 4 weeks ago. Would it be helpful in the face of persistent symptoms to test this patient again? No. Well, exactly. And this is where the Choosing Wisely Canada recommendation comes in. And actually, this is helpful for both diagnosis and for monitoring. So if there's a patient who has previously been ANA negative or borderline positive, do not reorder ANA for monitoring patients because it doesn't really reflect any change in their clinical or rheumatological disease. And if a previous ANA test is positive, do not reorder ANA for monitoring patients because, again, it doesn't really help tell you how the disease is doing. So the bottom line is, if you look at that and you see the patient has had an ANA done, whether or not they have a confirmed rheumatological disease, there is really no point in ordering it again. The only time you might order it again is if your patient's symptoms have significantly changed from when it was originally done and you think that a new condition might have evolved. But if they're already known to be positive, there's no value in repeating it. And if they're negative or borderline positive, it has to be a significant change in clinical symptoms before you would really consider repeating it. So word on the evidence for this one. So the evidence for ANA testing comes from expert consensus, lab guidance, but there was a cohort study where they did look at ANAs and positive and negative ANAs and how often it changed. And the cohort study also confirmed that once a person has been known to be negative or borderline positive, repeating the ANA has an extremely low positive predictive value for change. What is an ANA? So ANA, anti-nuclear antibodies, so they're antibodies, and they bind to cellular components in the cell. So this is what the figure is showing. So they can bind to the nucleus, cytoplasm, or the mitotic apparatus. When you get the ANA result, you're getting two things. You're getting the titer, which is how much antibodies the person has, and you also get a description of the pattern. So is it homogeneous or speckled or mixed and so on. And all of those kind of help you tell about the type of rheumatological or inflammatory condition they might have. In terms of the titers, so 1 in 80 means that it's a very, very low titer antibody. So it's not as relevant, and a lot of people can have that. But the higher it goes, then you know that there's higher titers, there's more antibodies present. ANA is a very sensitive test, but it's not specific whatsoever. So if you suspect, you're like, this patient has non-specific symptoms, it doesn't fit anything, I'm going to do an ANA just to see if there's more, if it's worthwhile to work up more, then it's a helpful test. I would never use it as a screening test because so many people can be weakly or mildly positive and doesn't mean anything. In the context of symptoms, it's a good screening test. If the ANA is positive and the person has symptoms, then I do send off a confirmatory ENA test, which is extractable nuclear antigen, and it tells you a lot more details. Again, but if the ANA is negative, it kind of reassures you that this patient doesn't likely have a rheumatological condition, and I'm just going to monitor and see where things go. And then the last case example, you see a patient in your clinic with an elevated ferritin, and you're concerned about potential iron overload. What will be your next steps in the workup of this patient? Do it again, so that's one option, yes. Iron studies, yeah, very good. So this is a common reason for those that I see patients in my clinic for consultation, so I thought we can talk about it. So ferritin itself is an acute phase reactant, and it's released from activated macrophages, and it cannot solely be used for diagnosis of iron overload. So we don't order HFE genotyping for diagnosing iron overload from hemochromatosis based on serum ferritin values alone. And this is an important thing to consider. I work in the hospital as well. A ton of patients I see have very, very high ferritin levels, and it has nothing to do with the iron in their bodies. It has to do with the acute inflammation, malignancy, whatever it is that's bringing them to hospital. So hyperferritinemia has lots of causes besides iron overload, and I just wanted to take a little bit of time to talk about those. So, and many of these are not associated with iron whatsoever. So acute and chronic infection will lead to high ferritin. So will chronic inflammation, autoimmune disorders, malignancies. A common one I see in the outpatient setting is chronic excess alcohol consumption, and then liver diseases as well. So liver failure, which I see in my hospitalized patients, but also chronic viral hepatitis, alcoholic and non-alcoholic steatohepatosis. And then when you're thinking about association with iron accumulation, that's where hereditary hemochromatosis can be a thing, but also secondary iron overload transfusion and other less common cases. An important thing to consider is that individuals of East Asian descent have ferritin levels that are at baseline 1.5 to 2 times higher than the reference norms. So it's, again, another example of a test that you have to interpret in the context of your patient to really recognize, even if the lab calls it above reference value, is it actually above reference value or not? So in terms of workup for hyperferritinemia, much before we would think about iron overload, you would get a history to assess for other common risk factors for hyperferritinemia. Drinking lots of alcohol, risk factors for viral hepatitis, any signs or symptoms of inflammatory autoimmune conditions, metabolic syndrome and diabetes. So I see a lot of patients with metabolic syndrome, obesity that have as high associated ferritin as well. History of blood transfusions, family history of and family history of any kind of iron overload. And in terms of labs, the transferrin saturation. How do we get the transferrin saturation? So we send off serum iron level and a TIBC level, and then you can get transferrin saturation from those. And that's going to be key, and I'll talk about it in the next slide. But you also want to look for other reasons for hyperferritinemia. So CBC, creatinine, looking for elevated white count, looking for chronic renal disease. CRP is a more Again, a lot of these labs are recommended labs. You will have to then pick the labs that are applicable to your patient depending on what you get on the history. But CRP, if you're thinking about something inflammatory, you do the ALT and GGT if you're thinking that there's going to be a liver disease going on, and glucose A1C lipid studies if you're thinking about metabolic syndrome. So the evidence for testing for iron overload in the setting of elevated ferritin comes from expert consensus, but also from a cohort study, which looked at a lot of patients with iron overload from hemochromatosis and looked at what the ferritin levels were as well as the transferrin saturation. And essentially, the serum ferritin levels reflect an increase in hepatic iron content, but there's a significant false positive rate. So you can't rely on the ferritin alone, and you do have to look at the transferrin saturation. Only in patients who have a transferrin saturation greater than 45%, would you have to then consider testing for HFE genotype for hereditary hemochromatosis. If their iron saturation is less than 45%, it's most likely that the hyperferritinemia is from the other causes, and you want to be working those up and thinking about those more often. So going back to looking at the practice pearls to improve the value of lab tests used as an individual provider, use lab testing guidelines when available. So in BC, we have the BC GPAC guidelines, which actually go on guidelines for a lot of tests, which include liver tests, CRP, TSH, B12. And I find those guidelines are helpful because it helps you say, in these environments, I don't need to use this test, and helps kind of save that cascade of false positives. Avoid redundant testing. Again, the best way to do that is to know your patient, kind of leaning in with what our keynote speaker had mentioned. If you know the patient, you know what's been tested before, you're less likely to kind of repeat and overdo the test. Use of stepwise testing over order panel testing. So one example that we previously talked about has been thyroid testing. So if somebody's thyroid is abnormal, you do a stepwise testing of free T4 and, if needed, free T3 rather than ordering all at the same time. Another common one I see is hypercalcemia. So if somebody has high calcium, you don't have to order the entire panel. You might just start with the PTH, and depending on the PTH, then you do the subsequent results. Consider retesting intervals for individual lab tests. So we talked a little bit about those. Sometimes when you already have a lab result, there is no clinical utility in repeating it within a certain time duration. So we talked about the A1C and the 90 days for that. We've talked about TSH. So once you make a treatment change, 6 weeks from that. And ANA, once you know it's positive, no value in repeating it. So once you know the retesting intervals for your test, it becomes easier to say you don't need to do it again. And then know your specialized test. So example, when should you order HFE genotyping? You really have to know the ferritin and the transferrin saturation cutoffs and whether or not they're relevant before you would do that. So the kind of reflecting what Aaron mentioned before. So how do we as an individual provider know how we're ordering. One of the ways you can do that is by signing up for the portrait, where we do provide that kind of individualized feedback. So one example of a portrait might be, how often are you repeating a normal TSH test in your practice amongst your patients? And then you have a better sense of, oh, like this patient has had a normal TSH 5 times this year and probably doesn't need that. So this is a way of helping to review your own lab ordering practice pattern and seeing how you're doing. With that, happy to take any questions.
When we test the calcium level, is it better to do the calcium and then the albumin and calculate it yourself, or the ionized calcium?
Yeah, it's a great question. Albumin is also a negative acute phase reactant, so it can go down in settings of infection, and it may not be the actual albumin as well. So I would recommend, if you're quite sure the person is at their baseline state in the outpatient setting, you can do the calcium and the albumin, and you'll probably get a fairly consistent result. In the hospital, when there's lots going on with patients, I do tend to use the ionized calcium, and I have often noted that they can be quite different because the albumin calculation doesn't work as well. Once you start treating or monitoring, it's helpful to monitor using the same test as long as the patient is sort of clinically stable. So yeah, I would say, in the outpatient setting, if they're at baseline, calcium and albumin is okay, but ionized calcium will always get you a more accurate result.
What's your risk of rheumatological disease if you have a normal CRP and you do the ANA? So should you be doing ANA panel if your CRP is negative?
That's a great question. Actually, I think I tried to look at this literature very recently to see what the positive predictive value and negative predictive value for CRP is for rheumatological conditions. And I didn't see a lot of great literature on that. But in my clinical practice, inpatient and outpatient, I have never really seen any rheumatological condition with a normal CRP. CRP is very sensitive. I've seen people's CRP go quite high after very small, like even viral URTIs and so on. So if the CRP is negative and your clinical judgment is not that you're picking up like obviously swollen joints and whatnot, I think it would be unlikely. And I agree. I think if your clinical judgment is fine, the CBC, the rest of the labs are fine, CRP is negative, I don't think you're going to pick up a lot on the ANA, and you might get stuck with the mildly positive ANA and then having to chase the tail. And it becomes too complicated. So I think it would be very fair to say, in my clinical opinion, there's nothing going on, CRP is fine. Let's not do any more of that workup. With lab testing, I've generally found it's better to stop upfront rather than go down the path of testing, because then you'll catch something. The ENA will have one antibody, I promise you, that will be positive. And then you go down this path of how important is that antibody and so on. So there was another question Erin mentioned on portrait for hospitalized patients. Was it like, so we don't, our portraits are for family doctors in the outpatient interval, so we don't quite have portraits for hospitalized patients yet, but there are sort of research studies that I'm part of that are going on where we do provide data on 2 individual practitioners who work in hospitals on how much they order relative to their peers, just to get a sense. But it's a whole different beast in terms of identifying appropriate ordering in the hospital setting and what's normal and what's not. And I think there's a lot more research that needs to be done in that area. Josh says.
I'm interested to know where the norms come from. So if we look at a lab test and we see reference ranges, could you comment on where that comes from? Like, is it I presume we want to match that population that's come from to our patient. How do we know where it comes from? Or
yeah, that's a great question. And actually the norms different labs have different reference intervals because they all do their own standardization. And that's been like very complicated for something like TSH, because you can't just say that this is the cutoff to work with, because every lab has its own thing. And you do have to end up, like if you really want, there's some things that are commonly known. So for instance, we know people with East Asian descent are going to have higher ferritin levels, and you can expect up to 2 times higher than normal. So whatever your lab reported normal is, you're like, okay, I can expect more than that. But when it comes to like knowing how your lab sets its intervals and whether your patient fits into that interval, you do have to contact that individual lab and say, who were the patients? Because what they're doing is just looking at where the 95% of the population fits and then setting standard deviations based on that. But if the patient is sitting in front of you is not going to largely reflect the population the lab drew the 95% intervals from, you're just working up the wrong things and working up a lab abnormality that it's probably not an abnormality in the context of the patient. And until we get to that personalized medicine point where we can actually identify, is this lab abnormal for my patient sitting in front of me? I think we're almost in the safer bet of being like, do I even need to order the lab in the first place for this person? Is this something that needs a workup for or not?